everyone, and welcome to today's virtual dental series. It is my great pleasure to introduce Dr. John Chow, the inventor of the pinhole surgical technique. Dr. Chow is a graduate of the USC Dental School, where he also served on the faculty for 2 decades. He has also been a research assistant professor at the PG program at the University at Buffalo. So today he will share a step-by-step case-based overview of the pinhole surgical technique. We'll also have time for questions from residents at the end of the session. Dr. Chow, thank you very much for joining us today. The floor is yours.
Okay, it's a great pleasure to be with you. Thank you for the invitation. I've been looking forward to this. So let's get going. Okay, so it's just as a matter of introduction. This is basically looking at the upper arch, and this is using the pinhole surgical technique. Now this is 2009, so the technique has evolved somewhat. It's not exactly the same like it was before, but anyway, this is the immediately after surgery. It's about an hour, 15 minutes afterwards, and you have a little bit of collagen showing through the day after. Probably the patient probably forced her lip a little bit too much like this. And so no problem, we would pull it off. And then this is 2.5 weeks later. And then this is 16 years later. Now just look at the uppers. We'll show you the lowers a little later. So you can see how particularly involving the cuspids and that we have dramatic improvement using this technique. So it doesn't matter with pinhole how steep the recession is. As long as we have a healthy papilla, because we can overcorrect so well that we do get good results. This is the same patient on a lower that we did about 3 months later. So, and you can, what you want to look at is we have no keratinized tissue at 20 of 25, and yet after 1 week is there, and after 14 years, you have a very thick band of keratinized tissue right at the central incisor. So we can talk about what we think happened, but we regularly will get keratinized tissue recovered in situations like this. So all right. So basically, I need to tell you that I'm the inventor, of course, you've been told, and I'm the part owner. I'm the owner of the Chow seminars, and then sponsorship had been given by the Geishlake company that produces membranes. The objectives are, we want to, why gingival recession is a clinical necessity. We're going to summarize 5 key peer-reviewed references supporting PST, and then we'll do a case-based step-by-step protocol and show you how we do a case and identify the critical decision points and common pitfalls and apply post-op protection rules that preserve stability. So let's get moving with that. Of course, this is kind of, I'm not sure if it's necessary. We know gingival recession need to be treated because of increased root sensitivity, root decay, and also what's not written here is that there's basically a leakage, especially with class 2 Miller cases, where you have continuing invasion of the toxins and pathogens through the permeable barrier represented by the facial gingiva. So that's probably the number one reason why gingival recession should be treated. And the psychological impact, of course, patient self-esteem and smile and so on. And I mentioned that root fillings cannot, of course, address this permeability problem. So, and actually, in fact, class 5 fillings are routinely removed. Okay, so what distinguishes the pinhole surgical technique is that there's no scalpels, no sutures, and everything is done through Pinhole with specialized instruments. And we don't have it down here, but I can talk about why why we can get the results we do and why we have so little morbidity is because we do full thickness flaps. We actually reflect the entire periosteum from the bone. So we're not doing any split thickness flaps, and therefore that explains a lot of the minimization of symptoms that we get and how we get uh, uh, pretty rapid recovery. All right. So it does reduce symptom patient discomfort generally. We don't because need donor sites. It's a shorter procedure time. Basically, you can have a surgical procedure, but you spend time suturing. So we're taking away the suturing time. So you can, whatever it is that you do, if you remove the suturing time, you get to you get the improvement in terms of a time expenditure. And again, we have rapid healing because we do, we're not cutting any incisions. We're not making any incisions. We're doing full thickness flaps. So we're rapid healing and the minimum downtime. We do get swelling routinely, but pain-wise is not a problem. So let me play this. Just press.
Introducing Chow Pinhole Gum Rejuvenation's pinhole surgical technique. Before, conventional gum grafting required cutting tissue from the roof of the mouth. The gum is then cut over the area of the recession and lifted. The tissue from the palate is placed over the recessions. Once complete, sutures hold the graft in place during healing. Now, with the new revolutionary Chow Pinhole Gum Rejuvenation, gum recession is corrected without cutting or stitches. This new process begins with the tiny entry point that is made in the gum. Then, a special dental instrument is placed through the pinhole to free the gums with gentle movements. Once free, the gums are guided down into a healthy position. When the recessed gums are corrected, tiny collagen strips are placed inside to help stabilize the gums. Incredibly, the pinhole heals rather quickly and often overnight. When complete, the receding gums are corrected with a minimally invasive treatment that is quick, easy, and instantly pleasing.
Okay, this is basically a patient education video. So now let me show you a case that I did very rapidly. It's a 7-minute video that we condense it into 1 minute. So this is a patient that came in just really wanted it done because he had to do a national commercial. And when he smiles, that cuspid shows through. So last minute, I decided to include him in my schedule, and we were able to do this. We skip a lot of basic steps, but this is something you can do once you get some expertise. But generally, you have two pinholes, but in this case, just one, because to save time. And he agreed to go with me to that night to a meeting where he could become the the eyewitness, be the patient that would that would describe his experience to the doctors there. So we had a lot of fun doing it that way. So anyway, so this is you have the pinhole, you have the full thickness flap, and we release the tissue right around the papilla more, and then we put collagen basically underneath the papilla, and that stabilizes the flap, and some of it comes to the buccal, and that takes care of it. And this is a very quick type of. Do I have any more on that? After that, okay. So so this is all right. So we'll move on from here. So so let's go back to the first case that we first showed you. So basically, we were treating. Where's the cursor? Okay, so we're treating basically almost every tooth, well, the first molar to the first molar, uh, and uh, and so we find that, and I emphasize that when I teach pinhole, is that it has definitely a strong advantage when you do multiple sites because you can do it all at one time. You don't have to do it in sections because you're not doing any grafting. So with this particular case, because it is appropriate for for this um, uh, for this uh, for this to be done as a pinhole surgical technique case, we decided to do this back in 2009, December 16. So just as a way of describing this, everything has to be removed. All the fillings and the root has to be prepared so that it's pristine and not in any way clogged or diseased. All right, so let's. In the meantime, if you have any questions, feel free to ask. Now, on the uppers, on the uppers, let me just tell you what basically happens. In the full arch case, basically, if there was not heavy recession, we'll put a pinhole over the cuspid. But if there's recession, we put the pinhole right about here, about 5 millimeters apical to the mucogingival junction. It's our first pinhole. The second pinhole will be over the second bicuspid, and that will allow us to release tissue all the way across, to the second molar. Then we come back to this pinhole, and then we release tissue coming this way. And then we can reach almost to the centrals. And then from this pinhole, we further go to the left and release tissue from here. And then eventually you put a pinhole over here. So this will be the third pinhole right between 8 and 9. And then from 8 and 9, then we go and release tissue to where we get to the cuspid. And then we put the pinhole over the cuspid. And then we go to the second bicuspid. And that'll be our fifth pinhole. And that will allow us access to release the tissue all the way to the distal of the second molar. So the uppers, are they able to see the pinhole on the upper? Yes. So on the uppers, you have the 5 pinholes I just described. On the lowers, if you do a full arch, it's basically the same almost every time. The first pinhole, if you're right-handed, you put it somewhere here. You can put it over the cuspid or somewhere here, and you can even put it over here. And then we release the tissue from this direction. The tip of the blade would always be pointing at the mucogingival junction. We don't go apical at all. So this technique is very safe in terms of protecting the mental foramen, the mental nerve. So, and then we keep on releasing it until we get to the molar. And then put the pinhole over the first molar on the mid buccal, and then we progress to release the tissue to the second molar. Then we come back here, and then we progress this way. Release the tissue over here, and then we use this pin, put a pinhole here, then release the tissue all the way to the first molar. All right, so there's some rules that we can go into, but I think I want to give you the big picture first. So root prepping is very important. We need to remove all that anything that's not sound dentin we'll remove, and then we clean it with the EDTA. So these are some of the instruments that we use. This is the whole kit actually. So these are the straight instruments we use to create the full thickness flap. And then we use these curved instruments to go between the teeth and elevate the papilla. So these are the papillae, the elevators, and these are the workhorses over here, and that would allow us to release the entire flap. So we put a pinhole, let's say, over the cuspid and through the cuspid. Then we put the tip of the blade on the bone, and then we release the tissue from the bone. So this is a full thickness flap. And then eventually, after we have released the tissue enough, then we can put a curved instrument that allow us to get underneath the papilla and elevate it down this way. So we get the papilla elevated. If we get the papilla elevated, then basically we have the flap at the place we want it. So papilla elevation is the key here. So I'm going to show them the live case here. Yeah, so this is I'm going to show you a case that I did recently, actually. So this is what we started with, and this is what we ended up with about an hour, 15 minutes later. So we do a lot of what we call enhanced overcorrection. So then we can allow the biology, the phenotype to take over and give us the best possible root coverage and give us the best possible tissue type, enhanced tissue type. So let's go ahead and play that. So the pinhole goes there. Now the instrument goes in. The tip of the instrument is a perpendicular, a 90-degree angle to the bone. And then this instrument then it releases the tissue from the bone and with different lengths. Okay. And so then we put another, when we have released it to the first molar, then we put the pinhole over the second bicuspid, and we go further back with the instrument and release the entire flap. Release the periosteum with the flap, and then from the pinhole, the second pinhole, then we go forward, go mesial, and then we further release the tissue beyond the cuspid. And then from the cuspid pinhole, then we proceed to go mesial to the central incisors. And then we will place another pinhole either between the two centrals or to one side or the other. And then from there, from that pinhole, then we release the tissue. And then to the cuspid. Okay, and then we reach beyond the cuspid to where we can get to the distal of the cuspid, and then we'll put another pinhole over the cuspid. Repeat the process until we get to the first molar. Then we put a second pinhole over there. Then we sometimes will go back and sweep in the opposite direction to get any of the tissue tags away from the flap, so we get complete release. So we go back and forth. Sometimes we go mesial from right to left, and then we come back, and then we'll do that. Now I'm actually using the papilla elevator to elevate the papilla. So if you have any questions, feel free to answer. I don't have a problem with that. If I left you a puzzle or something, and now, yeah, after I release a little bit more on the right, then I come back here and release more. So basically, it's a subterranean release of tissue. You don't actually see what the instrument is doing directly. You see it by its shape and its movement underneath the tissue. It's something that you develop with practice, but it's not complicated. If you keep the instrument perpendicular to the surface, then you tend to get the best results. Now we're also elevating the papilla. We're putting the instrument underneath the papilla, and then we're elevating the papilla. Now, when you see the papilla move, then the entire flap moves down. Can you see that? We're elevating the papilla between the central and the lateral, and the cuspid and the lateral. So as the papilla comes down, and then the entire flap comes down. We're not concerned about the size of the pinhole, and it heals up very, very, very nicely without suturing. We never had to suture any pinhole, even when they're much larger than this. So now you can see how we're able to get the overcorrection. We're releasing the papilla. As we release the papilla, it allows the entire flap to come down if we have already removed any attachment of the tissue to the bone, typically speaking. So now we pretty much get what we want already. You can see that. Now all we have to do then is to keep it where we want it by later on putting collagen. Now we're going to put collagen. First of all, put the collagen underneath the papilla. There we go. And then we keep on feeding it. Sorry that I didn't show that. So keep on feeding it into the papilla until it's stable. We use 2 or 3 at a time to save time. Let's move a little faster. Because I don't want to spend a lot of time doing this. Okay, that's pretty repetitive. So we feed it under the papilla first, and then that's like a tent pole that keeps the flap stable. And we put quite a bit on the buckle so that we get overcorrection of the kind that you're looking at here. So this is how we got from the before. If you look on the before on the left to the picture on the right. So that's basically what we do in a nutshell. All right. So let's move on. Now we'll do the lowers. Okay, this is a 5-minute on the lower. The first pinhole is between the cuspid and the lateral on the right side. The instrument is always pointed at the mucogingival junction. We never go apical to that. So we're never in any significant danger of injuring the mental nerve. So if you are concerned about that, when you do surgery in this area, pinhole definitely has a very good advantage. We just don't worry about it. We don't have a problem with paresthesia because we're not below the mucogingival junction at all. I still recommend we take CBCT and to find out where the ventral foramen is, but we basically don't have a problem. Same thing, we release the tissue, and then we release the papilla. Now we have released now we're going to release, not the release tissue on the right side. We're going to release the tissue facial to the anterior teeth. Now we're coming in I'm sitting at the truffle clock position now. Lots of hydration. Very important. And you have to be very careful with these papillae. These are very, very slant, very, very thin papillae. You don't want to break them. There are ways to treat it if you did break them, but we got to be real careful using the instruments. We actually have special instruments that can actually help not break the papilla, much slimmer than the regular ones. But anyway, so this is basically on the lower side, actually quicker. The lowest we do 4 pinholes. Generally, I don't take more than an hour for a lower. It goes pretty quick. So from this pinhole on the left side, then we go distally. And from this pinhole, I'll go to the mid buckle of the first molar. You see how we keep the instrument above the mental foramen by aiming only at the mucogingival junction. Now I put a pinhole over the first molar, and then I'm going distally to release the tissue over the second molar and the first molar. And then we use our papilla elevators. I'm elevating the papilla now. Carefully, of course, so I don't break any. Okay. And Now, we do have to make sure that that there are no tack tissue uh, that can keep the flap from being freely movable. Now, basically elevating the papilla using the curved instrument, going between the teeth, stay on bone, and elevate it that way. There you go. You can see now the flap coming up. You can see that? And we elevate the papilla, everything comes up. Then it's a matter of putting the collagen in to keep the flap stable. See how it covers almost half the clinical length of the tooth in some cases. And we like that because what we want that we tell the patient, we as the doctor and the surgeon, we will put the tissue at the best position possible for the body, for the biology of the body to work to give you the best results. If you allow the body's biology to heal in the maximum way, and then you get the results, then we don't tell the patient where the gum line is going to be. We basically say we're going to overcorrect it, and the body's biology will decide. And your compliance, of course, will allow the body to give you the best results in terms of the tissue type, the thickening of the tissue, the thickening of the zone of attached gingiva, and the root coverage. We're not looking so much for root coverage as we're looking to improve the tissue type. So we tell the patient that as far as the the goal of the surgery is actually to create the best tissue type possible, and then the body decides where the gum position will be. So where the gum position will be, and that'll be the very best that the body can do for you. So we don't get into it is successful because of the amount of root coverage. Our patients understand we're trying to create better tissue for the to give the patient the best longevity possible. All right. So this is more diagram that we show how the different instruments at different lengths allow us to reach the from the pinhole further back or further forward. So that's the basic difference between the instruments, the length of the shank. See, this is the final position. And there are different things patients not supposed to do. Basically, don't touch the gum for 6 weeks. Until last year, the patients have been told you don't brush the area of the surgery. That means the facial for 6 weeks. And last year, I came up with what's called the brushing stint. And can you give me one? So the patient will wear that stint. It has windows on it. It covers the gums. It has windows on it. So the patient put the stint on, and then the patient can brush. So now our patients will have pinhole. They can now brush their teeth and not brush their gum. So that's basically what we don't want. And what we don't want is something like that. Now the window on it, it covers the gums. We would take a digital image of the wound after we finish. Then overnight, my staff will make something like this, and then so you can brush your teeth with this over the gums. And so we'll give them very stringent instructions as to basically don't touch it, don't fool around with a wound, don't even try to purse your lips like that, and don't disturb the wound. Then we have the best results. All right. So this is the stint I'm trying to tell you about. So now you can brush it. Actually, I got a patent on it, but this patent allows anybody to use it. Any doctor can use it. They're just not allowed to teach it to other doctors without my permission. And if you want my permission, my permission, of course, I will give it to you. So, but that's the only reason. Only reason it's not. It's for any doctor who want to use it for this purpose. You can actually use it and put it over implants. You do implant surgery, you don't want the patient to brush the gums. You can use something like that. Now we do have bruising. So sometimes we will have bruising, which is we tell the patient this is normal. What we don't want the patient to do, what this patient did was he has a he. I didn't know he had a habit, but when he came back 3 days later, what he did on Friday, he came back Monday. He had been putting his tongue over his lip and been pursing his lips. So actually he caused some of that collagen to come up. If we catch it the first few days, that's not a problem. So they would avoid brushing the gums all together for 6 weeks. After 6 weeks, and then we have them use a very soft brush, only brush up or down, not like this. And we watch them for 6 months. All right, so I want to finish on time here. So let's talk about the articles that were published on the pinhole surgical technique. The first article was published in 2012. It's a 33-month retrospective study of 43 patients, 121 resection sites, of which 85 were Class 1, Class 2 Miller, and 36 were Class 3. So basically, Class 1, Class 2, as you know, are cases where there's no loss of papilla. And Class 3s are one where you have loss of papilla. So basically, and so we divided because the results were different. Class 1, Class 2 actually has the same results. Class 3, of course, was much less. The mean recession of the study was 3.4. So it's not just shallow, basically shallow recessions. The average time per case was about 22 minutes if we do 2 or 3 teeth at a time. We're not talking about doing full arch here. And patient satisfaction, according to our survey, was quite good. So now this is the case that was published in the would you give me the journal? This is the case that IJPRD wanted to use as an illustration. So now, and so we had the post-op picture for 2009. This is what. Oh, how come it's not on there? There you go. Anyway, this is what shows. Now this picture on your right on the screen is actually 2023. So it's way past the publication of the first study. But anyway, you can see how we're able to generate more keratinized tissue around most of the teeth that we treated. It's thicker, especially around number 10 and number 11. And even where you have basically class 1s, we even increase the keratinized tissue over there, and this is something like 18 years. So in this first study of 33 months and 43 patients, for the Class 1, Class 2s, we were able to get 81.2% of the teeth to have full coverage, complete root coverage at the end of the study on the average. If it's Class 1, Class 2, no loss of papilla. And the Class 3, because it went down to 41%. But what's really interesting, I want to point out to you that if you look on the bottom, can you move the box over? At the bottom, we started with keratinized tissue baseline at 0.8. When we finished, we were at 3.0 at the 33 month mark. Okay, so we actually gained 2.3. There was a computational error. So we gained 2.3 millimeters on the average of keratinized tissue after the surgery. So we're very confident that we will gain keratinized tissue, thicker tissue, um, uh, following the surgery. So we did catch that computational mistake in our second publication, which is 14.5 years. That's coming up. So actually, remember that actually at the end of the first study, it was 2.3. So we did gain KT. Now, and it was accepted for online publication January 25. Now the actually print version of it will come out May this year, May 26th. So, and you see this one here. So now basically the CRC complete root coverage went from 82 now after 14.5 years to 77.9, 78%. Still not bad. Still not bad after 14.5 years. So we're happy with that. Now, this here shows, where's my cursor here? So this actually is trying to show that there's slightly more keratinized tissue at the end of 17 months, 17 years, compared to the 33 months. So this is kind of when we published it, it was a 7-year case. Well, now it's 18 years. All right. So now there's another clinical trial. It's a randomized clinical trial comparing Pinhole with the subepithelial connector tissue graft conducted at Buffalo. Dr. Shipley, the chairman of the department, did the connective tissue graft, and I did the Pinhole. So we took several trips, and so by a flip of the coin, it was decided which side gets what. So at the end of a long study, we're able to show that that both grafting and Pinhole, in terms of root coverage, is about the same. In terms of even patient morbidity or symptomatology, we're about the same. So Dr. Shipley was very, 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 very good. So his patients didn't have any more pain than my patients who I did Pinhole for. Now, if you look at that, it's very interesting that if you look at the 1 year on this tooth here, you're using the graft, it's absolutely fabulous. This is great. But look at the tissue, it's really, really thick. So we're looking for thick tissue. CTG is a wonderful procedure. I think you can't get better than that. So now for Pinhole, tissue was pretty good. And actually, there's a better tissue match here. So you're looking for tissue match, you might make a case that this might be one advantage of Pinhole because you don't have the thick tissue here. That might be obvious. But if you're looking for longevity, resistance to overbrushing, definitely this CTG has an advantage. So now the difference, the difference between the two actually is in time. In time, because this doesn't show here, but the average procedure that Dr. Shipley did was about like 43 minutes. And the actual time that I took per tooth was about 22 minutes. So time-wise, there's definitely an advantage with Pinhole. And another study came in. This is the radiologist who was interpreting with my Pinhole CBCT. I was taking CBCT 2 or 3 years after the surgery, and she noticed that there's bone gain just by happenstance. So she decided to do a study, and then she was able to show that that comparing the before and after CBCT, the 96% had the mean value of bone gain greater than zero. In other words, there was a little bit of bone gain. At least we can say that with Pinhole, we stopped the bone loss. So this is radiographic evidence of some degree uh, of, um, of, um, of a positive result. Now, interestingly enough, uh, I was able to publish an article in the Journal of Cosmetic Dentistry on March 2025. So this patient came in with this situation here. So, so what do? You put a whole bunch of crowns on. Some of them are long, some of them are short. No, if you go ahead and uh, do do surgery, do grafting, you'll take several appointments. So the patient came to me and say she heard about Pinhole. So what can Pinhole will do for me? She flew in from Texas, I think. So I said, well, I scratched my head, I studied it. I said, well, if you're game, we'll do we'll do the prepping of the teeth. We'll make provisionals for you, and then we'll do the Pinhole all the same appointment. So we actually did the prepping, did the pinhole on upper and lower arch, and then we put provisionals on her, and she wore that for about 9 months. Then eventually we brought her back, and then we did the permanent restorations. So this is the left, this is the before, this is the after. So we came up with a term called crown shortening. So crown shortening can be done with the pinhole surgical technique. So we have 27 class 3 areas and that we did surgery on, and then we did something like 10 crowns. So this is the before and after. Okay, so I'm actually ready for Q&A.